Good evening, everyone, and welcome to our last Ask the Doctor webinar of 2021. Some of you guys have stuck with us all year long. Some of you guys even longer than that, so thank you for that, and we welcome you to tonight's webinar. For those of you who are new here, my name is Shelley Kurian with Skypass Foundation, and we host these monthly educational webinars. We try to do them once a month, and we've been fortunate to have some of the world's leading experts in movement disorders join us and answer questions on a wide variety of PD related topics. And tonight is no exception. I'm excited to introduce our panel of experts from UT Southwestern to you guys tonight. Joining us, we've got Dr. Gary Lemack, who is a professor of urology and neurology at UT Southwestern. We've also got Dr. Roopa Vemulapalli, associate professor of internal medicine, specializing in small bowel diseases. And we also have with us Dr. Stephen Vernino, a neurologist specializing in autonomic disorders. As you guys know, that's our topic of discussion tonight. And of course, my lovely co-host who's chomping down on her salad, Dr. Shilpa Chitnis. She'll come on the video here in a second. There she is. Dr. Chitnis, as you guys know, is a movement disorder specialist at UT Southwestern, and she also serves on the board of directors here at Skypass Foundation. She'll be conducting tonight's interview. Our panel tonight is extremely accomplished, and the titles that I read off are not accurate or complete, I should say, reflections of everything that they do. They all have very large, accomplished bodies of work behind them, and so we're thankful to all of you for doing what you do and for taking the time to join us tonight. As you guys know, our topic for tonight is autonomic dysfunction in PD. We got some great questions that you guys have registration, and we will address those during our time together, but we want to keep this session as engaging as possible. So there's two ways in which you can interact with us tonight. We've got the chat box at the bottom of our screen. You'll see that down there. There's an option there for a private chat if you want to send myself or any of the panelists a private message. There's also an option to send a message to where everyone can see it. And if you have any experiences or if there's something that you resonate with, any comments and feedback, that would be a great spot to put that in. And I will be interacting with you guys via the chat box as well. You'll also see a QA box at the bottom of your screen, and that would be a great spot to put questions that you want the panelists to answer specifically that are related to our topic. We kindly ask that you guys not put questions in the chat box because it can get extremely chatty and it can be hard sometimes to keep track of all of the questions. So if there's panelist specific questions on our topic, please go ahead and put that in the QA box. And with that, I will shut my video off and turn it over to Shilpa.
Okay, well, thank you, Shelley. And it's just a pleasure to have this panel over here. I have had a relationship with all of them for a long period of time, referring patients, being friends. Steve Vernino is really truly like my partner in crime and really probably one of the most influential people for where my career is where it is today. So it's really great to have him. Okay, so since we're talking about autonomic disorders, I think it is important for our audience to understand what is the autonomic nervous system and what it does. So Dr. Vernino, over to you.
Yeah, thanks. Thanks for putting this together, Shelley and Shilpa. I think the autonomic nervous system is one of those things that we don't have to think about very often. It's the part of our nervous system that controls all the automatic functions of your body. And we'll be talking about a few of those this evening. These include things like regulation of your blood pressure, control of or modulation of digestion, sweating and temperature regulation, bowel and bladder function, and a number of other things. And so most people don't have to think about their automatic nervous system or autonomic nervous system, but when it doesn't work right, that's when things start to go wrong. So it's the autonomic nervous system includes some circuits in the brain, as well as the nerves that go out to the different organs of the body, ranging from the skin, the blood vessels, the heart, the guts, and so on. And then Roopa may also discuss that there's a separate sort of autonomous nervous system within the GI tract that can operate independently, but also communicates with the larger autonomic nervous system as well. So when these things start to go wrong, patients may have difficulties with digestion, with regulating their temperature, with feeling lightheaded because their blood pressure is too low or too high, and things of that nature. And then with respect to Parkinson's disease, I think the reason we're talking about it here is that autonomic dysfunction is pretty common in Parkinson disease. And if you want, Shilpa, I can explain my take on why that is. So I think a lot of people know that Parkinson disease is associated with the buildup of this protein called alpha-synuclein in nerve cells, and in particular the alpha-synuclein protein builds up and gets collected in a little blobs called the Lewy bodies that sit in nerve cells, and it's thought that either because of those Lewy bodies or associated with it, the nerve cells are unhappy and they tend to die. So those Lewy bodies build up not only in the nerve cells that control movement, cause troubles with movement as typical Parkinson disease, but also in autonomic nerve cells. And there's a lot of similarities between the cells that release dopamine and are involved in movement and other cells that release things like norepinephrine and are involved in the autonomic nervous system. And so it's pretty clear that in Parkinson disease and related disorders that have alpha-synuclein as part of the problem, the autonomic nervous system is often affected.
That's wonderful. And so I'll just segue to Dr. V to complete, the part of the involvement in the enteric system.
So as Dr. Vernino has very eloquently said before, about the autonomic nervous system. So that the digestive system has a separate entity called like enteric nervous system, and that one controls the bowel regulation and also the motility of the stomach, the esophagus, and the small intestine and the colon. So some of the non-motor symptoms that happen in Parkinson patients, which are pretty common, are due to the derangement or dysfunction of this enteric nervous system that leads to constipation and nausea, and also feeling full after meals that can lead to decreased appetite and weight loss and so forth.
Wonderful. And so over to you, Dr. Lemack. Why is there urinary system involvement in PD patients?
So thanks, Shilpa, and appreciate you asking me to join this group. So yeah, the bladder, just much like the bowel, is controlled through the central nervous system, but also through peripheral nerves, and anything affecting autonomic function through any mechanism certainly can affect the bladder and particularly the sphincter. And so the way the bladder normally works is it should just fill up sort of unconsciously. We really shouldn't have any sensation of that filling until we reach a point of fullness, at which point you trigger a number of events, but one of those events is to void and to urinate and to contract the bladder and to relax the sphincter and allow people to urinate completely. And a lot of times in patients with a variety of autonomic disorders, including Parkinson's patients who have this, that goes awry, and it can go awry in a number of ways, which we can talk about. But the most common thing is abnormal signals are created by the bladder that otherwise wouldn't normally be perceived, and create these sort of micro contractions of the bladder, which shouldn't happen, and ultimately result in a variety of urinary symptoms. The most common of which is kind of urgency, frequency, you can't get to the bathroom in time, having accidents, those kind of things. And the troubling part, we can talk about this, is that there's just so much overlap with other things that can commonly happen with patients of this age. And so the difficult part is sorting out what's from the Parkinson's, what can we attribute to other problems, prostate, bladder problems, prolapse in women, those kind of things. And that's where it gets a little tricky. But yeah, very common problem in patients with Parkinson's disease, especially older patients.
Thank you, Dr. Lemack. And so, Dr. Vernino, I wanted to ask you, and we've had this discussion, we always think about, some research projects around it. Why do you think that there might be two phenotypes? Because, even when we were in med school, we learned that if somebody came in feeling lightheaded, dizzy, had a syncope, and had just started with their symptoms, then you worried whether this was really, PD, or was it something else, like an atypical form. So now, we're seeing these two phenotypes as either, autonomic involvement first and then brain involvement, or brain involvement first followed by autonomic involvement. Does this have any significance?
Well, I think you're right. The dogma or the way of thinking was that people with Parkinson disease, as they advanced, more and more body systems would get involved, including the autonomic nervous system. And so the thought was that autonomic symptoms like orthostatic hypotension, feeling dizzy when you stand up or fainting, was something that occurred relatively late. But now we recognize that the autonomic nervous system is probably involved early, and sometimes it is the earliest finding. As you heard, constipation can be very early manifestation, of course, not specific for Parkinson's disease, but in retrospect, one of the earlier manifestations. And then we've seen a number of patients who present to my clinic first because of troubles with blood pressure regulation, who ultimately evolve into more typical Parkinson's disease as time goes by. So true that that usually the severe autonomic symptoms come later as the Parkinson's disease advances, but not everybody is the same that way. And then you were alluding to atypical Parkinson's disease. So there is a condition called multiple system atrophy, where the autonomic dysfunction is particularly bad and occurs particularly early. And the features of Parkinsonism are not as typical as we see in Parkinson's disease, and the response to treatment's not as good. But not everybody that begins with autonomic dysfunction ends up being MSA. And I think that we appreciate that that's true.
Yes, thank you. And so, you're one of the few people, I think, definitely in the state of Texas, but even probably in the country, who actually runs a very busy, autonomic lab. And so can you just explain to our patients that when we send them for autonomic testing to you or to your colleagues, what does that entail?
Sure. So one of the challenges with the autonomic nervous system is it's a little bit difficult to just measure in the office, at the regular office visit. You can measure blood pressures and so on, but we have some more advanced testing that allow us to better characterize what's going on, and is the blood pressure problem really due to problems with the autonomic nervous system, or perhaps it's due to something else. And similarly, Dr. Lemack and Dr. Vemulapalli have tests that can help us sort out other causes versus true autonomic dysfunction. So in our autonomic laboratory, we do a series of tests. One test involves looking at sweating function to see if the nerves that control sweating are working properly. We also do tests that look at the regulation of the heart rate. So one important aspect of the autonomic nervous system is to control the heart rate so it can go up and down appropriately. And then we also look at blood pressure regulation, and that involves non-invasive things like an EKG wires and a blood pressure cuff. And then we have the patients do some breathing exercises, as well as tilt the table up and down to look at the changes with respect to changes in gravitational position. So that we look at the data from those tests, and we can estimate whether the problem is really the autonomic nervous system is not working, or perhaps something else is going on, like medication effects or low blood volume, for example.
Thank you. And then just if you can add about the skin biopsy that now we have started to do for testing.
Yeah, thanks. So we as we talked about earlier on, Parkinson's disease and these other related disorders are associated with the buildup of alpha-synuclein. And so obviously we can't typically do a brain biopsy to look for alpha-synuclein. But now, very recently, we've gotten the ability through some laboratories that can measure alpha-synuclein in biopsies of the skin. So a skin biopsy is a relatively minor procedure, a little bit of numbing medicine, and then a punch biopsy. And that skin has little nerves, and in cases of Parkinson's disease or related disorders, we may be able to see the alpha-synuclein actually within the skin biopsy. And if it's there, that's not normal. That test doesn't precisely differentiate Parkinson's disease from multiple system atrophy or other types of disorders, but it does tell us that this is some kind of alpha-synuclein disorder, and really helps make the diagnosis, along with other tests that you may have heard about before, including brain scans and so on.
Yeah, thank you. And so over to you, Dr. Lemack. So what is your, when you get a referral with these patients with Parkinson's with urinary issues, what is your approach towards evaluation and diagnosis and management?
Well, I think first you just kind of, like with anything in medicine, start out with a good history and try to get a little bit more information, because there really is a variety of bladder disorders that people present with. As I mentioned, sort of the most common, of course, is urgency, frequency, urgent continence, leakage, those kind of things. But many patients will also have, difficulty voiding, don't feel like they empty, have to double void, have to triple void, have to get up 5 times a night to urinate. For women, they may have more likely have things like recurrent urinary tract infections and sorting that out. So I think the most important thing first is kind of figure out what is the main problem. And, we as urologists generally break it down to, is it a disorder of filling or is it a disorder of voiding? And that's not as clear as you might think it could be, but we try to sort of break it down to that. And then once we have that sort of accomplished, then we'll try to, do maybe diagnostic tests to figure out. So the most common tests we'll do as urologists are something called bladder function tests, or what we call urodynamic tests. And that essentially helps out figuring out if a person is leaking, why are they leaking? What's causing it? Is it because the bladder is having spasms? Is it because the outlet's not strong enough? Is it because the bladder doesn't stretch very well? Is it because the bladder's small? If they're having problems voiding, is that because of their underlying neurologic disease, their bladder and their outlet aren't communicating appropriately? Is it in a woman from big prolapse, the bladder is dropping? Is it from a man from a big prostate? Are there some other factors? So this test does allow us to help distinguish those. In some cases, can give the neurologist a bit of a idea of what's going on urologically and may give them some insight into what's going on neurologically too. So it can be helpful sometimes from both sides. And then of course, after that, once we have that testing, sometimes we'll do other tests, look in the bladder, what we call cystoscopy, if that's appropriate, to get a feel of what the bladder looks like, or the outlet looks like, or the prostate and so forth. So those are the most common tests we do, but sometimes we do some things very, very simple. Avoiding diarrhea, for example. Avoiding diarrhea is something we send patients home on. If somebody comes in and tells me, I'm voiding 10 times a day and 5 times a night, but that might very well be due to their overactive bladder from their Parkinson's. But on the other hand, it might be because they're drinking 4 liters of Coke a day and they're making 4 liters of urine, and nobody told them that that probably wasn't the best idea. So, you kind of take things for granted, but you really shouldn't. So a diary can be very helpful in kind of figuring out where we're at and which direction we go on. So sometimes it's very simple things that can help us start in the right direction, but those are the most common things we use.
Yes, thank you. So one of the symptoms that patients with Parkinson's disease complain about is nocturnal polyuria. And what are your suggestions for addressing that?
Yeah, so making a lot of urine at night is a very common problem. Nocturnal polyuria, we do see that. So what people don't understand, and I didn't early on, was that our bodies change over time. And unfortunately, we make a lot more urine as we get older, regardless of whether you have Parkinson's or MS or anything else. So the average person who's in their 20s makes about 20% of their urine overnight. The average person in their 70s and 80s makes about 35% of their urine overnight. So you're doubling your urine production, and that's just baseline. That has to do with cardiogenic factors and other factors when you lift your legs at night and so forth. So that's difficult to overcome. We do talk about sort of dietary restrictions, fluid restrictions in the evening, pushing all that fluid earlier in the day. If they're on a diuretic, the timing of the diuretic, those kind of things. But if you've done all those things and you're still getting this relative nocturnal polyuria like you're talking about, where you're just making so much of urine overnight, when you look at things like avoiding diarrhea, there are some times that we'll intervene with certain medications that can drive down your urine production. And so those can be done, but you have to be very careful with those medications, of course, because they can alter your electrolytes. So we're very cautious about it. Sometimes it's really important to do something like a sleep study. Sleep studies can really show if this is really a nocturnal polyuria that's perhaps due to urine production or a sleep disturbance. So for example, something as simple as sleep apnea clearly can affect your sleep and the depth of your sleep, but actually sleep apnea also drives up urine production and make you even have more nocturnal polyuria. So getting a sleep evaluation, evaluating things like sleep apnea can both help you get into a better sleep pattern and drive down your urine production. So that's just some of the ways we sort of tackle it.
That's a really good point. I never thought about sleep apnea, but I guess I'll be thinking about it now. Thank you. So Dr. V, I want to ask you, so when you look at a patient with, and then for the audience, nocturnal polyuria is nighttime excessive urination. Just want to make sure you understand medical terminologies. So Dr. V, when you look at a patient that comes to you with idiopathic constipation, constipation for no reason at all, and do you ever think about, how many of these patients would end up developing Parkinson's? Does that thought ever come to your mind?
That's a very good question. constipation is seen about in 90% of patients with Parkinson's, right? But having said that, idiopathic constipation without any neurological abnormalities is also pretty common and mostly in women. But there is a good point to that, because it takes about several decades later, what was a presenting symptom, like when you're taking a good history, then the issue of constipation or a dysphagia comes. That kind of gives an idea, oh, maybe this was present long ago. But but the most common one is the, as we say, slow transit constipation or idiopathic, which is reason unknown at the time, or is another one is called the IBS constipation, which is kind of irritable bowel, where they have abdominal pain and the pain is relieved after the constipation is relieved. So these are the three common ones that we see, the common types of constipation that we see like in our population, in our practice. But that's a very good question, Shilpa. I have not kind of thought about that, but it's a good study to kind of look at, I think.
Yeah, like a longitudinal follow-up.
It's
been done, I know, but again, I mean, we see so much of it now. So, one of my really pet peeves as a Parkinson's neurologist is I don't want any patient to, get into trouble and die of something that is entirely preventable. Like one of the things that is quite preventable is aspiration pneumonia. And, patients do not ever listen. They don't do their speech therapy. Similarly, one of the things that is quite preventable is bowel obstruction. And, I've not had a lot because I'm talking about constipation day in and day out, but we hear of Parkinson's patients that die of bowel obstruction, which is so entirely preventable. So what is your approach? What would you tell our patients as to the best approach to managing their constipation and keeping track that, they have regular bowel movement?
So yes, colonic volvulus and intestinal pseudo-obstruction and megacolon are one of the catastrophic complications of constipation in PD patients. So just the general approach for managing constipation is the ones that we give, which includes, a good diet, which is high in fiber. And second thing is like adequate hydration. About minimum about 2 liters a day, that's kind of an arbitrary number that we use, that we tell patients to drink who have constipation. The second thing is that over-the-counter laxatives, which have been shown in several trials, that are quite effective, which is the polyethylene glycol or the Miralax. And there are also stimulant laxatives, which is bisacodyl. And when it comes to the point where a combination of the osmotic laxatives, which is the Miralax, and the stimulant laxative and the bisacodyl are not effective, then we move up to the prescription medications. Some of the prescription medications are lubiprostone, and we also have other prescription medications such as Linzess, which is linaclotide. And since for the past 3 or 4 years, we do have a prucalopride, which is motegrity, that also helps with the small bowel motility as well. So it helps with the slow transit constipation. So the main thing is, many people may not pay much attention to their bowel habits unless it becomes a big problem. So that's the key to make sure that having a bowel movement every day is very important, because constipation by definition itself is not having a bowel movement for 3 days or having hard stools, not adequate volume is also considered as a constipation. So I think, as you said, prevention is the key up here, making sure that they pay attention to their bowel diary, so that they make a conscious effort to see, how often are they having a bowel movement. And then if that's not the case, then trying to increase their medication intake, and also like a combination of the medications to help them have a bowel movement would be very important.
Thank you. This is wonderful information. And I, cannot overemphasize for my patients that if you do not have a bowel movement, you are not absorbing all of the levodopa, carbidopa that we're giving you. So if you're constipated and you come to me and say, increase my dose, I'm not going to do it, because I want you to have a bowel movement first and try to absorb, what you are already taking. And then, if that is not the case, then certainly we can increase the medication. So yes, the management of constipation is super important.
If I could add, this is really more about
Yes.
recognizing these issues and taking preventative measures. And I think water fluids is probably the number one thing. We've talked about urination, we've talked a little bit about blood pressure, sweating, bowel function. One of the risks that people get is oftentimes because of their urinary problems, they self-restrict their fluid intake, and that's going to lead to all kinds of other problems. So we are also strongly impose at least 2 liters of water intake a day, and as Gary said, to try to get that in early in the day, like right from the beginning. I tell my patients a big slug of water first. That's part of your morning routine to get things moving. And that actually has been shown to actually help in blood pressure control. One of the issues that patients get is this orthostatic hypotension. When they stand up, their blood pressure gets low. And that can be particularly problematic first thing in the morning for a variety of reasons. But a large intake of water, plain water, taken in pretty quickly actually has been shown to offset that morning drop in blood pressure quite well. And that gets you off to a good start of the day in terms of water intake. The other thing related to blood pressure is that these patients who have autonomic dysfunction can actually get high blood pressure when they're laying down, along with their low blood pressure when they stand up. And so most patients don't have symptoms of high blood pressure, but if you're laying in bed with high blood pressure all night, that will actually increase your urine output and also could lead to other end organ damage, because high blood pressure for 10 or 12 hours a day is not good for you. So we often have our patients sleep with their head elevated by 12 inches or more. That helps to offset the blood pressure changes. And also seems to, at least I tell them, seems to reduce their nocturia a bit. That often gets them more compliant with that intervention.
Yes, thank you, Stephen. Really, that was going to be my, segue into your next question, which was going to be orthostatic hypotension and what it means, and your approach to diagnosis and management. And we heard a little bit, but perhaps.
As I said, orthostatic hypotension literally means a low blood pressure when standing. And so it's defined as a drop in blood pressure more than 20 millimeters of mercury. That's on the top number, systolic number, or 10 millimeters drop on the bottom number, the diastolic number. So that's just a difference between either sitting or laying down to the standing position. And sometimes that blood pressure drops and you have orthostatic hypotension, but not many symptoms. There's been some studies that show that if the blood pressure, the top number, gets much below 90, then most patients will have symptoms. So that's really our goal sometimes. If the blood pressure drops from 140 to 110, that's orthostatic hypotension, but it's not really dangerous or symptomatic. And why does this happen? This happens because when you stand up, your autonomic nervous system is supposed to react to a potential drop in blood pressure by having nerve signals go out to your heart, to your blood vessels, to keep the blood pressure up. One thing that helps us tell that that's due to the autonomic problem is that when the blood pressure drops, the normal reaction of the autonomic nervous system in the heart is to increase the heart rate. And many patients who have autonomic causes of orthostatic hypotension have the drop in blood pressure without the increase in heart rate. So that can be a clue that it's due to the autonomic nervous system. Now, as with everything, heart issues, blood pressure medications, etc., can also lead to orthostatic hypotension. So you have to put all that in context, particularly in older patients who may be on a lot of medications. So when and then one of the medications that actually can worsen orthostatic hypotension is levodopa and other dopamine agonists, which can act as vasodilators. They can prevent the blood vessels from constricting like they should when you stand up, and worsen that orthostatic hypotension. The biggest risk here is the blood pressure drops enough that patients lose consciousness, fall, they can hit their head, break their hip, and that can be a devastating injury. So being aware of this problem, taking measures to avoid it, standing up slowly, drinking plenty of water, reviewing medications and blood pressure with your doctors is super important.
Yes, absolutely. So Dr. Lemack, I'm going to come to you, and I think that there are so many things that interfere in the quality of life of patients with Parkinson's, and these are questions I think even we as physicians are somewhat embarrassed to ask, but I think they're important to ask. So I'm going to ask you, how often do you see consults for management of sexual dysfunction in Parkinson's patients, whether men, mostly men, but even maybe women. And do you think sexual dysfunction is something that is quite under addressed in patients with Parkinson's?
So it's a very common complaint among patients who are referred. I would say the vast majority who are referred are primarily referred for bladder dysfunction, because I think that just sort of comes up in the conversation with their referring physician and neurologist. I don't think necessarily the sexual dysfunction is something that people bring up themselves for kind of precisely the reason you mentioned. People, even in 2021, which is somewhat shocking to me, people just don't talk about it as much. And part of it is because they probably feel like they're burdening us. They've got a million other things that they want to talk about, and they don't get to this, or maybe people don't feel comfortable talking about it. Even on the physician side, I think that's probably true a lot of the times too, if we're honest with ourselves. So yeah, I think you have to do some digging. It's our job, my job, to kind of get, bring that out and have people talk about it. A lot of times what happens, at least my guess when I'm talking to patients, is couples come in and they don't even talk about it themselves, which is too bad, but it's the reality. They just don't. And sometimes they've kind of just said, yeah, it's just not part of our lives. And that's okay, of course. But sometimes it was an important part of their lives, and they really just don't want to talk about it, don't feel comfortable talking about it, whatever it may be. So the first step is bringing up the issue exactly like you talked about, and letting people sort of talk about it in open and, in a fashion that's really, you're not judging them or anything like that. And then once you have that, start that discussion, then you can kind of tease out what's going on. Is it a problem with lack of desire? Is it a problem with the libido? Is it something you chase down that? Is it potentially related to testosterone issues? Or is it more of a mechanical issue or neurogenic issue related to erectile function in men, for example? Of course, you have older men that may have erectile dysfunction regardless of their Parkinson's. And so that's a very common thing too. The good news is that, we have treatments that are helpful, medications and other treatments. So there's definitely some options in the treatment of these patients, depending on how much they want to do about that, and they just aren't aware of it. So yeah, I think it's really important on us to bring those options up and talk to them about that. Female sexual dysfunction, also very common, both in Parkinson's and in older patients and younger patients too, for that matter. And I'd probably even more so in terms of being a quote unquote taboo subject, which is really too bad. The options for patients, for women with sexual dysfunction, are somewhat more limited just because we haven't come to that level of understanding, which is too bad. We're getting there. We're better than we were in terms of endocrine evaluation, endocrine treatments, and so forth. But we're not there yet, clearly. But I think there are some options to help, even if they're not going to address every single specific problem and complaint, but sort of getting there and getting some ideas and giving them some options and at least bringing up the subject is really important. So yeah, to answer your question, I think it's a very common problem in this age group, regardless of the presence of a concurrent neurologic disease, but certainly the Parkinson's patient as well. So I urge anybody who's listening to bring it up with their neurologist, bring it up with their primary care physician. And if those physicians aren't comfortable sort of addressing it, yeah, of course, get to a specialist, whether it's urologist, gynecologist, whatever it may be, because there are emerging options that are available.
Yes, thank you for addressing this very important question. And then what can we do to increase awareness really, within for patients, but also, like you said, for physicians, that, this is something that really contributes to reduce quality of life for so many people. Do you have any tips for that?
Yeah, that's the $1 million question. I think probably Pfizer spent $1 billion trying to raise awareness. I'm not sure how successfully, or whoever else is making Cialis and so forth. So, I mean, as difficult as it is yeah, you've got to make it more mainstream, and getting rid of that taboo is kind of the bigger issue. And, again, I thought we would have come a long way in 2021. But I think what we do is we just put it on the intake questionnaire, and I would urge the primary care and neurologist to do that. Hopefully they do that. I think, in my opinion, a lot of times what happens, it goes into that questionnaire and we just never get there because we've got so many other issues to tackle. And so what I would urge patients to do, and, tell your friends or whatever, is that this is something you should, hopefully feel comfortable bringing up, and bring it up early in the conversation if it's important to you. And if it's not important to you, that's fine too. But I would urge people to bring it up, because I think probably it's on the physician side too. It's not that people don't want to talk about it. It's just maybe they just don't think there are any other options. And then it's on us to kind of get to the right place where they can discuss those options.
And Shilpa, I think you can comment in the Parkinson's world, there's a better recognition now that a lot of these things we're talking about, the non-motor symptoms, really affect quality of life. And I think in the past, maybe even some in the future, in the present, there's a focus on tremor and balance and rigidity and bradykinesia. And once those are treated, the neurologist may sort of pat themselves on the back and not realize or not ask about the non-motor symptoms that are really still causing problems.
Yes, absolutely. One of the things that I've started doing now, there is a very nice non-motor questionnaire, NMSQ, that I basically just hand it out to the patient while they're waiting. And so they can just tick off everything and fill it off. And that makes it much easier for me to, pick the important things that we need to talk about. So I absolutely agree that it's non-motor symptoms are very important. So Dr. V, what do you think is the role of the gut microbiome in the pathogenesis of Parkinson's? And then to just add on to the question, do you think there is a role for, fecal microbiome transplantation in Parkinson's patients once they've developed the disease?
So as of now, the fecal microbial transplantation, the FMT, is approved for patients with refractory C. diff or persistent C. diff. C. difficile infection, which is a type of infection that happens in the intestine. Currently, not approved for anything other than that. The role of microbiome in the symptoms that bother the patients with Parkinson's, they have an important role in that, as in the same microbiome also is implicated in diarrhea, irritable bowel syndrome, with constipation, and the small intestinal bacterial overgrowth, which by itself can cause decreased intestinal motility and cause the symptoms of kind of food retention, early satiety, feeling of fullness, and kind of abdominal cramps. So there have been several studies that looked at the role of probiotics and the prebiotics. Prebiotics are basically, the fiber that acts as a food for the probiotics, which is the gut microbiome. There are also, the data is that based upon the symptoms that are predominant, whether this is constipation or whether diarrhea, certain strains of probiotics or the gut microbiome have been shown to be beneficial, but it's not like the larger number of strains are beneficial. For example, like 5 million versus 5 billion is better. It's not like that. And generally the multi-strain that includes the bifidobacterium or the bacillus, the lactobacillus plantarum, has been shown to be beneficial in decreasing the symptoms overall. So probiotics are also one of the key treatment that we use in gastrointestinal world, and some of them are the fermented probiotics, just like kefir. Kefir is a fermented drink that has several strains of probiotics, and kefir has also been shown to be very beneficial in C. diff too, in combination with some of the other antibiotics. So a high fiber diet, which acts like a prebiotic and a probiotic, adequate hydration, and with some over-the-counter laxatives will kind of help for the gut to maintain its function, to kind of help the intestinal motility and decrease in the symptoms of the constipation and bloating and so forth.
Thank you so much. And I'm going to read a few comments even from patients that some of the symptoms, dryness of eyes, cold extremities, and also, sweating. So I do, Dr. Vernino, maybe you can comment on these.
Yeah, sure. So, we talked about the autonomic nervous system and the nerves that go out to the limbs, to the skin, to the blood vessels. And, that part of that is very important regulation in terms of regulating the temperature of the limbs, the temperature of the body. So patients who have Parkinson's disease and other types of autonomic disturbance often don't regulate the blood flow in the limbs very well. And so they can get color changes, blood pooling, changes in the temperatures. If you have blood flow, that tends to pool in the lower extremities, in particular when their legs are hanging down for a long time. They can get kind of red or purple and sometimes uncomfortable even. That's the impairment of the blood vessels being able to contract and move that blood back toward the center of the body. So what can help with that would be things like compression garments to add a little bit of extra compression on those veins and blood vessels, or elevating the limbs periodically throughout the day. And then there's a lot of questions here about regulation of temperature and sweating. And so similarly, if and a lot of times the problems are most noticeable when there is a sort of imbalance between different parts of the body. So if, for example, the arms and legs are not sweating very well, not regulating blood flow very well, then often in a compensatory way to make up for that, when it gets hot, people will sweat more in their head, in their chest, and under their arms to try to offset that lack of sweating in other parts of their body. So patients will often come in complaining of excessive sweating, when in fact, if we test them or get a better or closer history, it turns out they're not sweating in the arms and legs, and the excessive sweating is more in the head and the upper part of the chest and body. So that's pretty common. And then changes in temperature for the same reason. The limbs, hands, the feet, legs may get more cold or hot, depending more on the environment than regulated in a constant range.
Yeah, thank you. And so Shirley Redmond has a question. Can dysautonomia cause problems with the lymphatic system? Example, cause lymphatic system to be sluggish, lymphatic fluid pooling in certain parts of the body?
I don't know that I have the answer to that. I mean, there's a close relationship between the autonomic nervous system and the immune system. But I think, our understanding of lymphatic system is pretty rudimentary. I think most of the time when we see swelling, color changes, temperature changes in the limbs, we both associate that more with vascular regulation, the regulation of blood flow to the skin, the increases in pressure in the venous system that causes edema, and so on. So that'd be a more likely explanation as opposed to lymphatic failure. But we don't really know that much.
Yes, absolutely. And another question is about heart rate issues, that the maximum heart rate, the patient wants to know, my maximum heart rate is artificially low. It is usually like 110 to 120. So
yeah. So broadly speaking, we have two arms of the autonomic nervous system, the parasympathetic and the sympathetic side. And it turns out in the alpha-synucleinopathies like Parkinson's disease, the sympathetic nervous system is a bit more impaired than the parasympathetic. Sympathetic nervous system is what would make your heart rate and blood pressure go up when you go out to exercise or when you're under stress. Or keep your blood pressure up when you're standing, for example. That's why orthostatic hypotension can be a big issue. But when you go to exercise, you need the sympathetic nervous system to increase your cardiac output, increase the heart rate. And if that is insufficient, you may not be able to get the heart rate up as high as you might like, because you just don't have the nerves just aren't there to drive that heart rate up. And so that can limit exercise tolerance, for example. People can get fatigued more easily when they try to exercise. And I think that's probably what the question was related to.
Yes, and Dr. Vernino, if you can also tell us about your multidisciplinary MSA clinic. I know it is not a Parkinson's clinic, but and then what it entails, and also what the objectives are of a multidisciplinary clinic. Do you think such a clinic would also benefit for patients who have, Parkinson's disease versus MSA?
Yeah. So this conference is going to highlight that the problems that patients with these disorders have or extend beyond the nervous system, and this is particularly true for multiple system atrophy, which some of you may know is a related disorder, but distinct from Parkinson's disease. And multiple system atrophy, as the name implies, involves a lot more systems. So these patients have very severe bladder involvement, more severe bowel involvement, more severe autonomic failure in general, and tend not to respond as well to the typical Parkinson's treatments. So because we're dealing with, and they have also things like sleep problems and so on, and MSA tends to be a more progressive disease, leading to more disability over a shorter period of time. So because all of those systems are involved, and also because patients who have these difficulties have difficulty with mobility and getting to lots of doctor's appointments, a multidisciplinary program allows us to bring together a number of specialists, as we're doing on this call here today, to provide input and coordinate the plan of care. So in our MSA clinic, patients can come to the clinic one day and see us neurologists. They can see a nutritionist who can talk to them about diet and swallowing. They can see a sleep doctor, an autonomic doctor, and a movement disorder doctor, and even when necessary, palliative care doctors. And then others, like Dr. Lemack, are part of our MSA program and make themselves available to address the bladder symptoms and so on. So we bring together those experts who understand these diseases, that understand they have to be managed in collaboration with each other. So we wouldn't want to start a medicine for one symptom that's going to cause a problem with another. So that's the concept of a multidisciplinary clinic. And certainly that could be beneficial for Parkinson's disease patients for all the same reasons. Although we started that with MSA just because those patients progress faster and typically have more severe multi-system kinds of problems going on.
Yes, thank you. Shelley, do we have any other questions? I think I've answered most of them.
We do. Sharon asks, how common is a runny nose with PD?
I can answer that too. It is actually common. Interestingly enough, it's called Rhinorrhea. This is just a fluid that runs. It's actually quite common. Steve?
Yeah, I'm not sure that I agree. You see that from time to time, and I'm not sure whether that's an autonomic problem where the nasal secretions are abnormally increased, or whether it's similar to what we see with drooling and other sorts of symptoms that go along with that. There's many symptoms that we recognize in association with Parkinson's and related disorders that we may not fully understand where they're coming from.
Yeah, thank you. Shelley, you can go ahead, you can ask them.
Yes, we got one with registration. This attendee says, my husband has trouble with taste and texture of foods. Also, almost everything he eats causes nausea or severe heartburn. And because of this, he doesn't eat much. Any comments or feedback?
So first of all, if any type of the food is causing heartburn symptoms, I think it would be beneficial to do an upper endoscopy to see if there is anything else going on, such as people can have the signs and also features that are related, that are occurring from the acid reflux itself, such as an esophageal ulcer or inflammation of the lower part of the esophagus. There is also another entity called reflux hypersensitivity, where even though when we do the endoscopy and take a look inside the esophagus, the lining appears completely normal, but then patients do have a lot of symptoms that are precipitated by food. In those, if that's the case, there are certain medications that can help to decrease the hypersensitivity. So I think for your husband, if it's not already done, a GI evaluation, starting with an upper endoscopy, followed by what we call a 24-hour pH esophageal manometry, to see if there is, if this is an hyper acid secretion or if this is a normal acid secretion with a reflux hypersensitivity. That diagnosis can be established, and the medications and how we can deal with the situation can be tailored according to the results.
Yes, thank you. David Wilson wants to know, shortly prior to my PD diagnosis, I had a period of uncontrolled crying, big blood pressure fluctuations, big increase in pulse rate, dizziness and double vision, treated with Alexa Pro, and symptoms subsided. Is this autonomic nervous system, and what are the chances of returning?
Well, it's a good question. I think we've talked a little bit today about the more typical associated features of autonomic failure, if you will, the failure of the autonomic nervous system work well. But there can be some imbalances, especially early on in the disease, and then it's hard to know whether there could be associated with that some labile mood, which can be common in some of the neurodegenerative diseases as well. With sometimes elevated heart rate and blood pressure is appropriate in a period of emotional distress. So it's hard to know. But we sometimes do see marked fluctuations, sometimes even high blood pressure when in early stages of autonomic dysfunction. That particular set of symptoms sounds like it may be some of the emotional lability that goes along with Parkinson.
Yes, absolutely. And Sharon wants us to know that she drinks very hot water in the morning before coffee, tea, or food, and it really helps with constipation. And I think I will agree. Thank you, Sharon. Juanita.
If I could add though, Shilpa, I think heat is another thing that can often be difficult for patients to deal with when they have autonomic dysfunction, especially in hot Texas summers. Heat will cause blood to tend to go to the periphery, to the skin, and may result in lower blood pressure. So, and as I mentioned earlier, mornings can be particularly problematic for low blood pressure. So you might, a lot of patients have come and say, I feel faint every morning. And after we get a good history, it turns out that they are taking a really hot shower and standing up for 15 minutes in the shower every morning. And once you point out, well, standing, heat, morning, those are all not good times for causing low blood pressure. And once you point them out, they're like, oh, I guess I could I like a hot shower, I could take it later in the day, or I could turn down the heat a little bit or sit in the shower to maybe reduce some of those symptoms. So be a little careful about heat because as we talked about, sweating function sometimes is impaired, and heat tends to lower blood pressure anyway.
Yes, thank you. So there's a question about, I've experienced a few of these dysfunctions, excessive sweating, excess saliva without drooling, but only for a short period of time. Is it normal for these to be a passing event, or do they come and go throughout the journey? And I'll just make a comment on that. It also depends on whether you are in your medication off state or medication on state. In the medication off state, when your medicine is wearing off before you take your next dose, it's reported that people definitely can have, sweating. I had a patient who had drenching sweats. We had to literally put towels all over him, and we gave him his medicine. 30 minutes later, he was dry. So I think that these, are definitely related to off states and on states, but welcome any other comments.
Yeah, I think that's right. We especially as in a bit more advanced Parkinson's disease, it can be a bit of a roller coaster, right? The medications can be helpful. Sometimes there are side effects when you're in the on state that are some of which are autonomic related, and then things can get shut off, and there are other types of problems. So it's good to take that, as I'm sure most Parkinson's doctors do, take that history of the fluctuations over the course of the day.
Yes, thank you. So Botox treatment for underarm sweating. So yes, interestingly enough, there are two botulinum toxins, brand name Xeomin and brand name Myoblock. They are both now approved for treatment of underarm sweating, as well as they're also approved for pylorrhea, which is, excess drooling that comes from saliva. And one question, so one more round of discussion, Dr. Vernino, on heart rate and exercise. You stated my situation exactly, but what can I do to exercise better?
Well, I think it's good to maintain exercise, just to realize that the intensity may not be able to tolerate as much intensity as before. Aerobic exercise is good for maintaining heart and lung health. Sometimes it's a matter of adjusting the exercise program so that you may have to exercise for a bit longer at a lower intensity to get the same benefits. But really, we often limit exercise based on maximum heart rate. I'm not a cardiologist, but the maximum heart rate is an important number. As you get older, just normally, your heart rate can't go as fast as it did when you were younger. And with autonomic dysfunction, that may be even more so the case. So I think, again, very good hydration associated with prior to exercise will give your heart a little bit more volume to work with and may allow more endurance even if the heart rate doesn't go as high.
Yes, thank you, Dr. Vernino. Any other comments from you, Dr. Lemack or Dr. V? Any last famous words?
I have a question for Dr. Vernino. How often do you see postprandial hypotension in Parkinson's patients?
Yeah, I see it pretty often. It's not terribly predictable. Some people have very bad autonomic failure, don't really have trouble with postprandial hypotension, and others have that as a prominent symptom early on. What we're talking about here is a feeling of lightheadedness when people stand up after eating a meal. So when we hear about that, and just very simplistically, I know there's a lot of factors that go into that, but simplistically, one could imagine that if you take in a big meal, maybe with a lot of carbohydrates, that the blood flow to the gut will increase to facilitate digestion and everything else, and that's blood that's not available for circulating to the muscles and up to the brain. So orthostatic hypotension can be worse. So I talk a little bit about the timing of that. Sometimes it's a matter of not eating such a big meal in the morning. We've mentioned morning being a bad time, and also being careful about the volume of the food and the type of food. Alcohol with the meal can make this all worse. So if that's an issue, we often will first recommend smaller meals spread out through the day a bit more often. And then if it's really a problem, there are various medications that one can try to essentially reduce the diversion of blood to the guts after eating. But yes, this can be a very problematic thing sometimes for patients.
Thank you so much. I think with that, we really at the end of the hour. Thank you, Dr. Vernino, Dr. Lemack, and Dr. Vemulapalli for really very, very engaging discussion and great information. And I will turn it over to Shelley.
Thanks, Shilpa. Dr. Vernino, just one last quick question. We've recently been doing some work with the YOPD community here in Dallas, and one of them had a question that I just want to quickly address. They ask, are symptoms of autonomic dysfunction seen more, less, or at about the same frequency in young onset versus typical PD?
My impression is it's a bit less often, but I think it really depends on, especially in genetic forms of Parkinson's disease, what the mutation is. There are certain, and Shilpa may be able to answer this even better, certain genetic forms of Parkinson's disease that do have a lot of autonomic failure, but some don't. So I think on balance, they tend not to have as severe of autonomic dysfunction as we see in more typical sporadic late onset Parkinson's disease.
Great. Shilpa, anything to add to that?
No, I agree. That's it.
Okay, wonderful. Thank you all so much for being here tonight. This was an excellent discussion. Doctors, I really appreciate your time. I know our attendees appreciate it as well. Thank you all for joining us tonight. If you're watching this live or if you're watching this recorded, thank you for spending an hour with us. Just a quick announcement before I let you guys go for tonight. We are going to be continuing these Ask the Doctor webinars in 2022. We're going to be switching up the format a little bit, but we fully intend on continuing this every month in 2022. We do have a special program specifically for care partners that I want to make you guys aware of that's starting exactly 4 weeks from today. We're doing this program in partnership with Tribe Wellness. It's called Caregiver, Exercise, and Connect. This is going to be an 8-week class that is sponsored by Skypass Foundation, which means it's completely free of cost for you to attend. It's designed to just give caregivers an avenue to connect, avoid burnout, practice self-care, get some exercise, and connect with other caregivers in the community. So please sign up for that. Information is on our website at skypassfoundation.org. If you or anyone you know would be interested in that, we would love to see your names on that registration list. And of course, if you have any questions about that or any of our other programs, or perhaps some ideas of how we can better serve you, please feel free to reach out to me. info@skypassfoundation.org is the best way to communicate with us, and we would love to hear from you and keep the conversation going. And with that, we will call it a night. Thank you all again. Have a great holiday season, and we will see you next year. Thanks, doctors. Have a great night.
Thank you.
Thank you.